Hello everyone, welcome to Raaonline. I'm Dr. Abhinaya, I'm a consultant pediatrician. So in the chapter discussion on nephrology and urology, the next topic of discussion is on a neuropathic bladder. This is going to be a brief presentation. So we all know neuropathic bladder dysfunction is common in children, especially in children with neural tube defects. So what causes this neuropathic bladder? So a bladder and a urinary sphincter malfunctioning, which is resulting from a central or a peripheral nervous system cause, will cause this neurogenic bladder. So this can be congenital or this can be acquired. Example, after an injury, after a tumor. So it can be both congenital or acquired. What we usually come across in pediatric age group is congenital. After congenital causes are neural tube defects, sacrococcygeal teratomas, etc. Acquired causes are tumors to the spinal cord and trauma. So, neural tube defects are quite commonly seen. Some are occult neural tube defects also. So, what happens? What is the cause of these neural tube defects? So, when the neural tube fails to close spontaneously between the 3rd to 4th week of gestational age, it results in neural tube defects. Most common neural tube defects are meningocele and myelomeningocele. So what happens in a neuropathic bladder when there is bladder and sphincter dysfunction? Neuropathic bladder can have urinary incontinence. These patients can have recurrent UTIs, hydronephrosis because of a VUR and detrusor sphincter dyssynergia. So in such instances, we have to do a preliminary investigation like renal ultrasound followed by MCU and most importantly a urodynamic study. So what is this urodynamic study? And what information does this give? The urodynamic study will give information about the bladder volume, the bladder pressure, the sphincter tone and the abdominal pressure. So, this is very important for us in our evaluation. A neuropathic bladder can be either uninhibited. Uninhibited means continuous hyperreflexia is there. So, continuous contractions in the bladder, that is uninhibited bladder. A normal bladder which has normal volume and normal contractions. Third, it can be a completely atonic bladder where there is no detrusor contraction at all. So, a neuropathic bladder is more prone for renal damage, especially because of the detrusor sphincter dyssynergia. So, because of the renal damage, there is a functional obstruction of the bladder outlet and the bladder can go for hypertrophy, trabeculations and a high intravesical pressure. So, per se, because of a neuropathic bladder, this pressure will be built up in the bladder and this will get transmitted into the upper urinary tract causing hydronephrosis. So, children with neuropathic bladder are more prone for UTI. They will also have VUR. So, which will compound to the problem. So, if you have a child with neural tube defects and if you find that there is a detrusor sphincter dyssynergia, there is both medical management and surgical management. So, for medical management, we give oxybutynin and we ask the parents to do a clean intermittent catheterization every 3 to 4 hours. So, CIC will evacuate the bladder. There will not be any overflow incontinence. There will not be a high bladder pressure. So, it will prevent the VUR. And if there is a VUR, high grade VUR, antimicrobial prophylaxis will be started. If the patients have recurrent UTI and they are not responding medically, then surgical procedures like this is a temporary surgical procedure which is a percutaneous vesicostomy. Botulinum toxin is one option where it is injected into the detrusor or into the sphincter.